like minds.
I love this song. I like the whole mix. Anderson, kudos to you.
Hello, everyone. Welcome to today's Global Health Council Fireside Chat and Solidarity Panel. Do feel free to share where you're logging in from and say hi to people that you might recognize in the chat, and enjoy the music. We're going to get started in just a few minutes.
But I can't be in the chat.
I've been walking with my face turned to the sun, weight on my shoulders, a bullet in my gun. Oh, I got eyes in the back of my head, just in case I have to run.
All right, everyone. Good morning, good day. Thank you so much to those who are greeting us in the chat. I see we have so many great participants from around the world. I see South Africa, Uganda, in the US, everywhere from Florida to DC. Keep going, keep using the chat to connect with your fellow participants on this day, and we're going to go ahead and get started. My name is Lori Adelman. I'm Vice President of Influence and Engagement at Global Fund for Women, and I'm also an advisor along with Sarah Hillware on this session. This morning, I am joined by a very special guest, Winnie, Byanyima, Executive Director of UNAIDS and Undersecretary General of the United Nations. We are going to have a fabulous discussion today. I'm so thrilled to be talking to you, Winnie. Thank you for being here and joining us. Before we get started and jump into a discussion with Winnie, I just want to go over some housekeeping. This is day 2 of our summit. Yesterday was an incredible day. We heard from so many superstars, Solomay, Steph Kimu, so many people, and we saw the discussion happening, both live and in real time, and it continued on social media. So we hope to keep that going today. You can be part of the discussion on social media using the hashtags GHLS20 and hashtag democratize global health. That's hashtag GHLS20 and hashtag democratize global health. And as a reminder, this year's symposium is focused on pandemics, politics, and privilege, the good, the bad, and the ugly US legacy in global health. And so that is a rich topic. Day 1, we had a lot of reflection. We had some really good discussion and framing of these problems and issues, and we look forward to another day of deep reflection and dialogue about how we should approach US investments in global health and initiatives with a stronger focus on equity, justice, and humility. So I personally am so looking forward to hearing some wisdom from our special guest today. And immediately following this fireside chat, you're in for a treat. We have a dynamic panel set up of very fabulous speakers, and they will also be addressing these issues and building on these discussions. So I want to go over to our special guest. Thank you again so much, Winnie, for being here. We're thrilled to have you. I want to jump right into it, and I'd love to hear from you a little bit more about this theme of the day and hear from you directly. What does it actually mean and look like to be anti-racist in the fight against HIV?
Hi, Lori, can you hear me?
Yes, I can. How are you?
Good. I'm so delighted to be here with you and the sisters in this session. I feel so privileged and indeed special to be here with you. Let me say, your summits are so important, and thank you for this great work you do, because you shape agendas, you challenge assumptions, you focus the agenda of global health. So why is being anti-racist important? Let's start here in your country, these great United States of America. In 2018, 42% of all new HIV infections were among African American people, even though they are only 13% of the population. Well, let me tell you something even more shocking. Did you know that in this country of yours, a Black child is 2 times as likely to die in their first year than a white child? Probably you knew that. But did you know that, in fact, Black children in this country, the richest country on earth, are more likely to die before their first birthday than children in Libya? Think about that. So it's so important to understand why that is so. Why such huge racial inequalities? Let's go to the world. We had 4 centuries, 400 years of the slave trade across the Atlantic. It was followed by 100 years of colonialism of our countries. That's 500 years of foreign domination and humiliation of people of the African race. Now, today, epidemics, pandemics, we know they thrive on inequalities, whether gender inequalities, racial inequalities, economic inequalities. That's what they feed on, and they widen them. If we are to fight and end an epidemic such as I fight HIV or COVID, we have to understand that it's about closing those inequalities, fighting those inequalities, including racial inequality. So for me, the fact that it is not talked about is itself tells me that this is the worst inequality, because it's so feared, it's not talked about.
Mm.
So I salute you for bringing it on the table. To be anti-racist is to say that let's look at everything, the systems, the structures, the policies, the rules, who is on the table, and examine them for racial equality. Let's not make any assumptions here, because there's been these 500 years of being crushed. So being anti-racist is different from being non-racist. Anti-racist means you challenge everything, the systems, the structures, the policies, the allocations, the language. You challenge everything and question it from the point of racial equality. That's how I understand it.
Wow. Challenge everything. I love that. And we need nothing less than that, especially when I hear some of those statistics that you're throwing out there, which unfortunately, you know, we're too familiar with here in the US. And just since you mentioned, oh, go ahead.
Because Laurie, if a policy is equal,
yeah,
or is neutral, it's not equal, is neutral, that doesn't make it racially equal.
Yeah.
Because of these 500 years of being crushed. So we have to go away from neutrality of policies, neutrality of language, and go to what will it take to even it up. That's anti-racism.
Such an important message, I think, especially for the global health community, who we are very science-based and data-based people. So this should resonate a lot. And because you mentioned COVID and some of the ways that COVID-19 has exacerbated these inequalities, I want to dig into that a little bit more. So of course, we have seen a lot of inequality during COVID. We've seen disproportionate impact on communities of color. We've also seen human rights abuses take place under COVID. But on the other side, recent data shows that the global uptake of PrEP continued to climb, even in the midst of COVID-19, which for me is a very hopeful statistic. And so I'm hoping that you can continue my hope and talk a little bit about how we can keep protecting human rights and how can we keep this fight against HIV/AIDS going even under COVID-19.
Such a good point you have made. There's a hopeful message and there is also an alert to make. Because if we look at the health impacts of COVID, again, you see how COVID is thriving on inequalities and making them worse, whether racial or gender, in terms of health. We have the data. I will not cite the data here. But then that's on the health. But when you look at the social economic impacts, even worse, because there you really see how racial groups such as African people, people of African descent, we are the short end of the stick. We are the countries that are worst hit socially, economically, health, not so much health-wise, but socio-economic-wise, but even health-wise, because when you see the knock-on effect on other diseases, on how capable the systems, the weak systems are able to deal with vaccinations of children, with TB, with malaria, it's weakening and weakening and weakening further. So the worst impacts are with us. But guess what? When COVID has been, where will it first be controlled? In the rich countries. It started in China, went to Europe, America, finally in Africa. But who will still be with COVID at the end of next year and the other year and the other year? It will be Africa. We'll be the last ones to be treated. So inequalities, inequalities, inequalities. But where's the hope? You're right. Even in this horrible situation, the heroism is from the most vulnerable people, those on the margins, people living with HIV, LGBT communities, sex workers standing up to fight for themselves, holding hands and supporting each other. That is why you get that figure of PrEP coming up, because people won't give up. We've seen people, young men, getting on their bicycles and going against lockdowns, risking their lives to go to get ARVs and to carry them and supply them to their friends, their neighbors, their community people. These are gay men taking care of each other. We've seen sex workers get up and speak up, not just for themselves, but for pregnant women, for other women, fighting for their rights as women against lockdowns. So this kind of challenge gets the heroism out of people, those who are most affected. Women living with HIV, walking long distances, going to get their ARVs to share with their friends, sharing their water for sanitation, for hygiene. There is amazing stories that I am getting because of my work that make us fight more and more. So yes, services, HIV services have been appropriated actually to fight COVID. In the beginning, we were so worried that we're going to see huge impacts, including more deaths related, AIDS-related deaths, more new infections, and indeed it's happening, but it's less than it could have been than our earlier predictions. And reason because communities have gotten together, raised their voice, and found solutions around how to share the HIV infrastructure, the HIV networks with the COVID response. So there is some innovation and learning on how to use the same services. So that's a message of hope that innovation is happening. People are standing by the solidarity is coming through at the grassroots.
Absolutely. Solidarity is that word that comes to mind, and you gave some really powerful examples of that happening at the grassroots level. That is really inspiring. And I know many people on this call participating in this discussion will take that hope and run with it in their particular role. I want to pivot a little bit to talk about education, because you've made education really a flagship initiative under your leadership. You launched Education Plus, really looking at African leaders and encouraging African leaders to invest more in secondary education for women in their countries. So I'm curious, connect the dots for us and help us understand the role of education for women and girls, especially when it comes to this fight against HIV and advancing their health and rights. Why is that so critical to this conversation?
Okay, I'm going to start with, because it's about inequalities. As I said, it's all about narrowing gaps between people, that people who are victims of an epidemic, a pandemic, it's not because they didn't behave well, or it's not because they were unlucky, it's because they happen to be unequal with others, lacking rights, lacking resources, opportunities, that they get to be infected with an epidemic. So I'll give you a story. I'm a woman, African woman, who is a global leader today. It's an honor, it's a privilege, but I came from a very ordinary background in a village in Uganda. Sometimes, not sometimes, all the time, I am reminded that I come from a category that's at the bottom of the heap. This inequality follows me, even though I'm a powerful woman at the top. I'll give you one story. When I was in New York attending a UN big meeting, the Secretary General and world leaders, Angela Merkel and so on, when I arrived, and I actually thought I was looking very distinguished in my African dress, I was getting my coat hanged, and this CEO, white man, comes right up to me and hands me his coat. So I picked the coat and I followed him, and he kept walking away. He had given me the coat. So I followed him and I said, what do you want me to do with your coat? And he turned red and he,
Wow.
and then the story doesn't end there. When I was now in the meeting room, it was a banquet by the Secretary General. So when we were about 300 people, I happened to be on the top table, sitting with Secretary General Ban Ki-moon, Chancellor Merkel, even Zuckerman was sitting on my table. So this man must have seen me on table number 1, and he must have been sitting in a corner in the back. When the lunch ended, I saw somebody running through past tables. He grabbed me, he pulled me aside, and he said, I beg you, can you ever forgive me? Never say that. He was shaking.
Wow.
It was the bias, thinking this is an African woman. She's the one who takes the coats in the cloakroom. So I live with this, and we live with this, and this is what I challenge. So this initiative about women and girls, when I arrived at UNAIDS and was looking at the data, I found a statistic that hit me, which was that if a girl can stay in school up to the end of secondary school, that she will reduce her risk to HIV by 50%. Okay, that's one. The other piece of statistic that hit me was that in Africa, sub-Saharan Africa, 4,500 young girls and young women get infected every week. This week that is ending, 4,500 of our daughters have become infected. That's a crisis. That's a crisis. So I felt if it takes them being in a classroom to reduce that risk by a half, why are they not in a classroom? So this initiative is about pushing the governments to wake up to this, that if they can roll out universal secondary education, even if it's not good quality, but a girl is in a classroom up to the age of 15, 16 when secondary school ends. And then I also found that if you put in other initiatives like address toxic masculinities of boys, remove sexual violence in the school space, give comprehensive sexuality education, you reduce the risk to a girl by even another 30, 40%. Wow. So it's not rocket science, we can do it. We just have to spend less on other things, tax more progressively, and it can be paid for. So that's what I'm about now. Reduce the risk of HIV to Black girls, African girls.
Yes, I'm absolutely, I think persuaded, and I hope many on this call are going to take you up on that and follow your lead on that. I know we only have a few more minutes. I cannot let this fireside chat go without mentioning that earlier this month, the American people did elect a new administration. We have Joe Biden and Kamala Harris as the incoming president and vice president of the United States. And so very quickly, in a few minutes, I'm curious if you can share with us some of your recommendations for this incoming administration, what needs to happen in the first 100 days, and thinking about who's in this room, what do we need to be fighting for with this administration when it comes to global health and especially HIV/AIDS?
Hey, you're asking me a question that is tempting because I might inject myself in your politics when I shouldn't. So I won't. Let me say this, that the American government, the American people have been leaders in global health, showing their big heart, their solidarity, and sharing what they have with the rest of the world. We've seen an America in the last few years withdrawing from that role. So of course, my big message is first to say the new administration, whoever they are, return bring back America's leadership, solidarity, leadership on global health, return back to the WHO, put back your resources in the WHO. You don't walk away from fighting a global problem. You stay until you solve the problem. That's my big message too. Continue fighting inequalities, racial and gender inequalities, the equality of all human beings. I think putting equality in the global agenda, and of course the national agenda, that's an internal matter of the country, but to have in our global development agenda equality as central, human rights as central, for me is the most exciting thing and my biggest ask of the new administration. And I look forward to the elections concluding and we start to build relationships that will solve these global issues.
Thank you so much. And I see many in the chat also, supporting that and mentioning some of the policies that they hope to see happen. So that's great. We just have one question left, and what I'll say, having come up in this sector of gender and development, it's so meaningful to me to see amazing, powerful, smart women, smart African women, really leading with their authentic voice. And that's something that you've embodied in many different roles, and you're really bringing forth such important points and also leading by example through your leadership. And so that's so meaningful to me. It's so meaningful to, I know, so many in our sector, and Lois and GHC have done a great job with this summit of really bringing forth and the amazing diversity that does live in our sector, but it hasn't always been that way. And so I just want to give you an opportunity, as to give any final words to any young women, and especially young women of color who might want to make an impact on the global health sector. And what advice do you have for them in this moment in particular?
Oh my God, I don't even need to give them advice, but celebrate them. I met Dr. T only recently. That's a young, brilliant African woman. There are so many out there. I'm excited with the change that is happening in your country, because again, I'm seeing the possibility of so many African American women rising and shining and having their chance to contribute. So I'm celebrating young women of color because actually their potential is there. Opportunities have often not been there for them. And indeed, that's why I'm fighting for these young girls in Africa. They are great. They have the potential to be, go to Mars. They have the potential to lead in every field. They need their chance. So thank you so much, Laurie. I so admire what you're doing, and I celebrate young women of color.
Thank you so much, Winnie. I'm so appreciative of you. Thank you for this great discussion. And I really want to thank everyone who is participating. Right now, we have a wonderful treat. We're going to transition onto another panel to build on a lot of the themes that Winnie addressed today, including inequalities. We're going to hear from different perspectives on this issue, including from journalists, doctors, and the grant makers. So really opening up and thinking from a multi-sectoral perspective, how can we implement a lot of the important values and ideas that Winnie has raised today. So just a reminder that if you would like to join us on social media, you can use the hashtags GHLS20 and hashtag democratize global health. And I am going to take the opportunity to, again, thank you for participating in our Fireside chat. I'm going to thank deeply Winnie for joining us. in your busy schedule and in the midst of a pandemic, which I know you are working very hard to keep the health services and keep the hope alive. And we thank you for that. I'm going to now hand it over to my colleague and advisor, Sarah Hillware, who will lead the next portion of this event, which is a dynamic panel.
Wonderful. Thank you so much, Lori. And wow, I mean, what a discussion. First of all, good morning, good afternoon, and evening to those tuning in around the world. And thank you so much to Ms. Winnie Byanyima for your thoughtful remarks on challenging systems, structures, policies, and the call to action to challenge everything. That just resonated so much with me, and I'm sure others listening as well. My name is Sarah Hillware, and I'm Deputy Director of Women in Global Health, a network of 35,000 women and allies globally. And so as an organization, our mandate is to challenge power and privilege for gender equity and health, meaning that while we start with gender, we know that we must look deeper to have a sector that truly reflects those that it's meant to serve. Historically, global health has been mainly a top-down, north to south enterprise, led primarily by white elite men. And we know that women are 70% of the health workforce globally, but only 25% of leadership. And furthermore, only 5% of leaders are women from low and middle income countries. So, you know, Ms. Byanyima is not the norm, but the exception, and this has to change. As a Black woman in global health, these realities are present each and every day. Having spent most of my childhood in Louisiana, I know the inequities that come with being a Black woman from the South, and then having spent also a lot of my years, particularly in high school and university in Washington, D.C., my hometown. Washington, D.C. actually had the highest rates of HIV infections in the country. And this disproportionately affected Black women and still does. But that's not a coincidence. Washington, D.C. At the time actually had a majority, the population was a majority African-American. It was called Chocolate City, for those of you who remember. And the headlines read, you know, that Washington, D.C. had higher HIV and AIDS rates than countries in sub-Saharan Africa. And so what does this tell us? You know, not only do we need to ensure equity in global health, but we need to close the gaps between the local and the domestic and the global. We can no longer look at global health as just a north to south enterprise, but we must look at global health as a participatory, flat, south to south, south to north enterprise. And we also, in the context of COVID-19, must stop separating the disparities that the Black community faces and other minority communities face globally from those that we see in LMICs, because oftentimes there are parallels. And when we separate these in our mind, it often leads to these dynamics of the other. And so, you know, really looking forward to a dynamic panel discussion. Today we have with us some really incredible women. We have Dr. Joanie Un, who's the board chair, interim chair of Women in Global Health. We also have today with us Rashida Peterson, who's at Global Fund for Women. We also have Dr. T, who's the UN Special Rapporteur on Right to Health. And we have Rosebell Kagemeyer of African Feminism, and she's a writer and journalist. So welcome. It's such a pleasure to moderate this session with you all today. So Joanie, I'll start with you. As a physician and public health researcher and founder of the Young Baines Leaders Association, and also as interim chair of Women in Global Health, what initially inspired you to work on issues in global health and women's leadership?
Thank you for having me. I think this is a
Joanie, we're losing you.
story of first working in health, myself almost dying at 9 years old.
and then having a physician saving my life, having my best friend at 12 years old practicing an abortion and dying from it. So from there, my passion for reproductive health actually.
Joanie, we're losing you, unfortunately. I'm going to have L Street Partners, who's helping to co-organize this session. If you can just please ensure that Joanie is able to get connected. Okay.
Can you hear me?
Joanie, you're back. Would you mind repeating your answer? Apologies, you were disconnected.
Oh, okay. So I think now we have internet being suddenly powerful and deciding when to work and when not to work. But I was sharing.
Joanie, unfortunately, we're going to have to come back to you as you're cutting out. So I'll have our organizers just work with you on connection, and then we'll come back to you. So next, I'll actually turn to Rashida. So Rashida, you're in a fascinating position, having started a consulting firm focused on advising donors, and now as a regional director at Global Fund for Women, a feminist grant maker. Your career is mostly focused on analyzing investments in and advising institutions on funding African organizations and diaspora initiatives in the US. Why did you decide to do this work?
Hi, Sarah, and thank you so much for the invitation today. I was really inspired by some of the comments from the previous Fireside chat, and the reason why I decided to do this work is because of that, because of so many of the things that that were mentioned before. You know, the connectivity of Black people around the world, and you mentioned some of the statistics that I'm based in Washington, D.C. and live here now, but also from the Caribbean, and have spent a lot of time, as you mentioned, looking at those links, right? And looking at the links of Black people around the world, and trying to figure out where some of the breakdowns and challenges are. And I think a lot of that comes down to the inequality. And I have chosen to focus on how can we move capital and how can we move investment, because that's sort of the space that I have chosen to operate in. But how can we do that in a way that causes less harm and is about focusing on bridging some of those gaps? I mean, you've mentioned some of the statistics. The statistics are really stark in terms of inequality from health, education, you know, pay, all of these things. So I think that that's the reason why I've chosen to support, particularly on the capital side.
Wonderful, yeah, and that absolutely, and I think that, you know, that's definitely one area where we definitely need to look at through an equity lens is the funding. So thank you so much for that. Joanie, I'll come back to you actually, now that you're back with us. So just to repeat the question, as a physician, public health researcher, founder of Young Bainese Leaders Association, and interim chair of Women in Global Health, what initially inspired you to work on issues in global health and women's leadership?
Thank you for the question. I think now I have better internet and then I can go straight without being interrupted. I was sharing my personal story of almost dying at 9 years old from a respiratory attack, and having a best friend of 12 having an unattended pregnancy and dying from it. And very early on, I really understood the link between reproductive health, health overall, but also the gender dimension of health. For me, it was critical to understand that if she had access to information at school, or for example, if she knew that she could say no to her unprotected sexual intercourses, well, she will not have been pregnant and will not have had an unattended pregnancy, which will result in an abortion. So I think for me, that was the main aspiration, but also seeing inequalities. Yes, I'm from Benin Republic originally, even though I'm currently working in the US and I'm in the global health space. But seeing inequalities in my community and in the world, for me, was the main driver.
Yeah, wow, wow, Joni. And I mean, just what a powerful story. And I think that also speaks to the inequities and the access to information that is actually had around the world with not only the Black diaspora, but those who are lacking that agency and really don't have that access that it is oftentimes assumed. So thank you, Joanie, for sharing that story. So next, I'll actually turn to Dr. T. So Dr. T, it's such a pleasure to have you with us today, and really looking forward to hearing from you as well, because I think your perspective really comes from this idea that we all have a right to health, and especially some of the issues that you've worked on in SRHR, illustrating, I think was really beautifully illustrated by Joanie. But as the UN Special Rapporteur on right to health, can you describe some of the ways in which intersectional inequities play a role in determining who has access to quality SRHR services? And also, what are some tangible steps that we can take in global health to hardwire a rights-based approach into our work?
Hi, Sarah, and thank you very much for having me this afternoon. And I think it's very important, to just set that scene, for all of us, that I grew up in apartheid South Africa, where my race, was something that was seen as less than and not worthy of these rights. And I know what it is like being a young woman myself, who is firstly requiring information about my own body and my own rights, and secondly, not having access to those facilities that can actually then affirm my rights by giving me quality, affordable, accessible services. And I was also quite annoyed as a young person, especially as a young woman, that there were so many laws governing my body, and there was something about how we are socialized that tells me, don't wear this, it's too short, or don't walk there, it's, and I just found this, I was just feeling so claustrophobic, physically and literally, because of the history of this country and where I was growing up, but also in many other ways where I just felt that I was not affirmed as a young woman. And so my activism is really a fight for my own survival and for people who look like me, who sound like me, who could never even dream, right? Where I come from, dreaming and getting a tertiary education and being where we are today is something that for many of my peers is not even something that was even in the realm of existence. So I know firsthand what it took for me to be able to be a young woman who's affirmed, who can advocate for her own rights. But then later on, because I was a medical student at the time, I qualified being that medical doctor who understood how my practice of medicine, how my clinical care was in itself something that could protect and promote my patients' rights. And so my advocacy moved from one-on-one in a consultation room with my patient to the bigger political issues around health, because I realized that even as a medical doctor, there were things in the system that needed to be changed that still were disabling and enabling of me to be the best doctor that I could be. And one of those important issues that I came to understand fully in my later years is the fact that a lot of the global health financing and funding and philanthropic aid, it comes with its own agendas. It comes with its own targets. It comes with its own deliverables. It comes with its own design, right? And it comes just with its own priorities. And I was also frustrated being a medical doctor who then had to translate all these programs, and often the priorities were not the same as the priorities that the communities where I was working at were identifying and needing in the moment. And a lot of those programmings, and because of how the contracts are designed, there was no sustainability. And what also then became something that really moved me was realizing that there was a certain sexism, racism that was embedded in a lot of the health messaging that was targeted at young adolescent Black girls in Africa. The advertisements that all of this money was buying was very paternalistic, was very much around fear and disease, right? And about me controlling my body so the world can be a better place. And I genuinely rejected that as a young woman myself, growing up in South Africa at the height of the HIV epidemic. And I knew, though, that there were other things I needed to do. So my protection, being a human rights defender, is for my own rights. I'm a beneficiary of my own activism. And because I'm using human rights standards, I know that the work will reverberate and be felt even beyond the spaces where I even occupy. And I think that's what's really important, is that we need to be more than just non-racist. We have to be anti-racist, because racism is embedded in the financial institutions, it's embedded in grant making, it's embedded in health communications and program design, it's embedded even in the different reproductive health commodities that are available in primary health clinics. And so me taking on this new role as the United Nations Special Rapporteur, I really apply, I'm going to apply a lens, that looks at the restoration of dignity. And I know it's an ideal, right? But restoration of dignity is open-ended. It requires me to ask people, what does dignity look like for you in this situation you find yourself in? What is the priority for you, as opposed to being prescriptive in how I approach this work? And I think it's by being clear about the different vulnerabilities, whether it's age, gender, class, religion, issues of migration, being undocumented. All of those, are not our identities. They are the situations we find ourselves in, and therefore those shouldn't be the reasons why our rights are abused. And it's my vision and my mission to ensure that we protect everyone's right to the highest attainable, standard of physical and mental health.
Excellent. I couldn't have said it any better myself. And I think one thing that I'm hearing that is a common thread between your story and also Joanie's story is really this this view that essentially the bodies of Black girls and women are should only be seen through this lens of how it affects the lives of essentially the white global north donors, which is I don't even have words. So, I think that's just, I'm really glad that you brought that to the forefront. And so with that, I just want to turn it back actually to, to Joanie. If maybe you could just say a few words about, why do we need those in the communities who are supposed to be served by the solutions actually at the forefront of designing the solutions themselves? Why is that important? Okay, I think we might have lost Joanie again. So
I'm here. Can you hear me?
Yes, we can hear you.
Okay.
Great.
Yes, can you please repeat your question? I'm very sorry. Internet is acting funny today, but I really hope it's good.
No worries, no worries. We're just wanted your quick reaction. So why do we need those in the communities who global health and public health interventions are meant to serve at the forefront of designing solutions? Why is that important to actually have girls and women, especially, but those who are from those communities that the interventions are being designed for, actually at the forefront of leading in the design of those interventions?
Well, that's a great question, and I will a little bit more than my first answer, which was more short and sweet and straight to the point. So maybe let me start with a key statistic to show a little bit of these inequalities that are actually prevalent in the global health era and transition to your question. While low and middle income countries represent 83% of the global population and 17% of high income countries, we only see 5% of women coming from LMIC being global health leaders. That's one discrepancy that I can understand. So 83% of the population are from LMIC, 70% are income country, but only 5% of global health leaders are, from this region. That's one discrepancy. But also one that I want to highlight is that when we don't involve a community specifically in designing a program or taking ownership about, what they really need, we cannot expect, a specific outcome. I used to say that funding needs to be driven by people's need and people's aspiration, and not the other way around. When we prioritize, let's say, agenda setting, or when we prioritize a specific policy, well, it needs to be based on what do the community really want, what do the community really need, but also how can we make sure that by addressing specific issue, we make sure that the community ownership is out there. Let me share this quick story with you. My first encounter with global health started 15 years ago because, of my personal experiences. And then I started implementing a couple of programs nationally with the Young Beninese Leader Association in Benin as a platform that reached over 10,000 youth on HIV and reproductive health. And we kind of very early on, we were very young. We kind of really early on had collaboration, very positive one with, big donors who kind of supported this vision. But we also realized that the whole designing from within was not necessarily what all donors were actually, looking for, and even worse or better, through a couple of engagement that I had at policy level with those international the nationals and leaders in the field. Yes, there's a lot of commitment, for example, for gender equality, for community-owned action. But again, how much of the decision-making power by the community health workers is taken by society themselves? So that's a big question that I want to ask. So here is what I learned about those perspectives from working in Benin, working now, in the US as a researcher, but also being part of Women in Global Health that I'm serving as an interim chair, and it's a fantastic organization, and I think it's a fantastic organization, and having women of color like yourself and Rupa are part of it are definitely critical. So those are key elements that I want to share. We first need to make sure that we understand the concept of intersectionality, allyship, so moving just from equality, equity, and justice in global health. Justice because we can remove the barriers that prevent the communities or women to actually take ownership. Second thing, power and privilege. They are both social, cultural, economic determinant of health. And I would even say they are also political determinant of the health. And they can either address inequalities or exacerbate inequalities. Third, we need to change and change, and we cannot address those if we don't understand our own privilege, our own bias, and impact that. And last but not the least, because we don't have enough time, diversity. Diversity needs to be beyond number. It needs to go beyond quota, but it also needs to be a little bit more about inclusion, a little bit about equity, but most importantly, about power. Let's make sure that is shared and has power.
Great, thanks so much. And so wanted also to turn it to our last panelist, Rose Belkagemeyer. So really excited to have you here with us. So you're a writer, campaigner, award-winning blogger, Pan-African feminist, and multimedia communication strategist. How did you get started in this work of storytelling, really looking at what stories are being told about people who look like us and people who are feminists and wanting to look at feminism from an intersectionality lens? How did you get started in this work?
Thank you so much. It's a pleasure to be here and listen to everybody and try to bring my own experiences as a journalist in Uganda and having worked in neighboring countries in the Great Lakes region and trying to bring stories every day on the platform I work on from different African countries. I've worked as a journalist in Uganda, and I think my interest in global systems, not only health, global systems of power, started when I worked in war-affected areas, and then realized that, you know, local people or people on the ground were not really in charge of whatever was happening. It was between the government and the huge international agencies and the huge sector, that there was really no room in that case for them to be heard. And I from these stories, I learned what it means to be at the mercy of different actors, which will hardly listen to you. And so I set a path to really understand what global systems look like on the ground, because it's very easy to look at them from a very big distance. But what does it mean for a person on the ground that lives this reality and the decisions that are taken without them? And how do we actually continue to push for the voices and the agencies of people on the ground that are being affected by this? Looking at the stories, I think it's very important from that journey to realize that global health dynamics, of course, mimic existing power dynamics in the world. And who tells the story? Like in many other contexts, the story has always been told by a white male, largely targeting a white audience. And people like me, people like in different African countries or the global South, have for a long time been subjects without or objects of fascination and obsession about what their health is and what their bodies are. And we all know, like, the history of medical racism runs alongside the history of racism and racist coverage of the bodies of African people, their politics, and their lives. So it's very important to know that these systems work in tandem, and there is no system in the world or architecture that is really innocent of these perpetuated systems that I think, like Winnie talked about, that have been perpetuated over 500 years. So it's very important. And as a storyteller, you have to realize which story, and sometimes the organizations, for example, which have the biggest audiences will tell you, oh, you know, we have a journalist in Uganda who's Ugandan, they know the realities, but that's only half of the story. The half of the story is that who has the power to determine what story comes out of here? Who has the power to determine the narrative? Often it's not probably the person on the ground. Even when they might see things differently, they'll be packaging the story according to what the particular media has always wanted. So we also have to look at a unique intersection in global health, this kind of medical racism with the intersection of sexism and how Black women's bodies have been treated for a long time. We have, for example, a recent podcast examining the history of pandemics in Uganda and how syphilis was covered and portrayed, and how they were portraying African Black Ugandan women as, you know, disease transmitters, like people who are not at existing in a system that disadvantages them. So the face of the disease was a Black woman, you know. So we need to look at how these storylines interweave with also existing medical expertise, but or of course with an underlying structure of racism. So it's very, very important to interrogate who's speaking, whose agency, but also beyond just victimhood, even when you have local experts, African healthcare experts, who gets to be seen. Often in research, the groundbreaking research, they are listed as a footnote, right? Mm-hmm. The voices are not the ones that we're going to see, and the unique stories they might carry will not come through. So it's very, very important that we interrogate who is speaking on whose behalf, and also largely also we need to interrogate the impact of this big global health architecture on indigenous medical knowledge, and the continued marginalization of indigenous medical knowledge in Africa has really seen because countries are tending to bend towards who is, you know, who is really funding them. We had at some point in Uganda, traditional birth attendants were being arrested on murder charges. You know, these are people who have been in our countries, in our social fabric for a long time, and they do serve a certain purpose. So for a long time, they were being targeted with murder charges. But then for a long time, people also pushed back and they said, we need to reform, we need to integrate them in the healthcare system to recognize the special function they serve so that they are part of the chain of the referral system. And things have improved since then. So, but this all rides on the idea that you don't know your own body, even when you have known it for centuries, even when you have had your own indigenous knowledge for a long time. So this is for me, these are the very important questions, but then also on who is funding, and like Dr. T talked about it, who is funding and who is pushing the agenda? What kind of stories then come? Even when we are pushing back against, for example, opposition forces in different African countries that are against sexual and reproductive rights, who even those who are pro these rights, what kind of frames are they giving us? You know, we know that many African countries were forced to liberalize their economies, and as a result, we don't have public healthcare system. So we depend on the goodwill of those who donate money to us. So at the end of the day, the global health infrastructure must be really examined also in the impact of capitalism on the lives of people, where you have a government, but the government is not really has no duty to your health. You have to continue to pay. Majority of people in Uganda, even me, I pay out of my pocket to access healthcare. So we need to continue to bring these narratives of how our health is interconnected with other global systems like capitalism. And thank you.
Thank you so much. Yeah, I think you brought up a lot of really important points, and you know, and it just keeps really, I think, coming back to this idea of the agency and the ownership of you know, women's bodies, and you know, Black women's bodies, African women's bodies, you know, which I find quite, you know, quite poignant, you know, just in this whole dialogue that we've had. And so now I would actually like to turn it to the audience. So we're going to take a couple of questions. Please do enter them into the Q&A chat feature you'll find in your toolbar at the bottom of the screen. And we'll have just enough time to answer probably 1 to 2 questions. So I do see some questions already here. So we'll go ahead and get started, I think, on this last question, which is, how do we get funding into the hands of people of color to do this important work of decolonizing and breaking down structures of power and privilege in health? We often pay those perpetuating inequities to fix them. So let's commit to getting funding into the hands of women and in LMICs and women of color. So I'll actually turn this question to Rashida to answer, and then we'll turn it to the rest of the panel to chime in.
So thank you for that. I mean, I think that that's, you know, what everyone has been saying. It really comes down to who is making the decisions from the perspective of who's in the room, and then who, you know, who has the purse strings. And we have to understand that in many instances, donors are not divorced from our society, right? So all the things that we were talking about, you know, that some of the esteemed panelists had mentioned before, you know, just so many things about power dynamics. Who are you speaking for? Who's in the room? Who's doing the research? All of these things, all of these inequities. The donors, you know, we're all in our society with all of these, with all of these inequities, and we're living with it every day. So what I would say to many people is just fund Black initiatives, local initiatives on the ground. If you're trying to solve, I mean, it really is kind of that simple. The challenge is that in many instances, once you've identified a problem and you've identified an entity that, you know, is close enough to the problem that they know the solution for their own problems, the trust and some of these things that we've been talking about, you know, then the barriers start to come up. Well, but they don't have an M&E system, but they don't have this, but they don't have a, you know, what about tracking, or what about this and this and this? And so I think my organization, Global Fund for Women, you know, we serve as sort of that intermediary. So we look at, you know, how can we do 3 things: learn, change, and challenge. learning. 30 years, we've been focused on funding grassroots movements over 30 years. We've had to learn and change. We've had to change our approach. We've had to push back on some of the donor communities when, when some of these issues come up. When you go into a room and people are talking with their big degrees, talking about how, how do we address this issue, and this in this particular community, and you say, just fund them. Fund them, give them the money. It's like, oh, wow. Oh my God. Well, how can you do that? So, so I think those are the main things. There's also one other thing that I would like to mention. In August, there was Black Philanthropy Month, and coming out of that, there was funding principles. When you're looking at centering some of these issues, I would compel people to go on the Black Philanthropy Month website as well to take a look at that initiative, and it gives you a framework, because I know there were some questions before about like, where do you start and how do you begin to get funding into the hands of people of color.
Mm-hmm, mm-hmm. Thank you so much, Rashida. And, I just have to commend the work that Global Fund for Women does. I definitely, and I can experience having run a nonprofit and now, also being number 2 in a nonprofit, that it's extremely difficult for, women-led and feminist movements, to really ensure that this funding is going into the hands of those who are in the communities, of those who can drive change. And we do have a trust problem. I think we, as a global community and also funders, really need to do a much better job at putting much more trust in the communities that they're seeking to serve. And so that actually brings me to my next question that I see here. So using global solidarity, how do we ensure the incoming vaccines actually reach communities, especially those who are hardest to reach, right? So just given this this COVID-19 pandemic that we're in, how do we ensure that vaccines are actually getting to the communities that they serve? And this will be the last question, so I'll ask just for a quick rapid round, 30 seconds each to answer this question, and in a context of intersectionality.
I'll just go for it. Last month, my colleagues at the United Nations, we released a statement on COVID-19 and vaccinations. And what we're calling for is global solidarity, because there's no point in richer countries hoarding vaccine doses because they won't reach their purpose. If none of us are healthy and safe, no one else is. And I think that's what's important. We need to advocate for people's vaccine and support all of the global movements who are calling for accountability, which includes transparency, which will build trust. And thirdly, we need to make sure that the people who are most vulnerable get these doses first. And we know that vulnerability in this world, it's still racialized, it's still gendered, it's still around people in the rural areas and those with disabilities. And definitely the health worker force and the essential services workers have to be prioritized.
Thank you so much. Next, I'll turn to you, Dr. Joanie Bewa, and then Rosebell, and then Rashida, last word.
Yeah, I think it's a really important issue. For example, here in my work at the University of South Florida, we realized that, the CDC released a report, a document about vaccine allocation and priorities and equity, for example. So for the US, but we need to have a global framework like that for not just the US, but all countries, right? That can be spearheaded by WHO and other organizations. So kind of talk about how do we want to make sure that, low and middle income countries, African countries.
Joanie, you muted part of the way through. We're not able to hear you.
That they are not just part of being in clinical trials, but they can also have the vaccine. So that's more at the policy level. But secondly, and very briefly, I think we can also tap into the power of private sector, corporate in low and middle income country, but also the power of philanthropy in low and middle income country. We know that there are resources in the but the private sector, the philanthropy, and the rich, billionaires can also need to organize themselves so that we can tap into this potential for the well-being of all, including the most vulnerable, because we should not let anyone behind, especially not during this pandemic. We need to build back better, or we need to build forward better with everyone and no one left behind.
Great, thank you. Rosebel and then Rashida, 30 seconds each. Thank you.
Thank you so much. I think we have a very, very big job ahead, not just to avail vaccines. The pandemic came at a time when there was a very big anti-vaccination movement across the globe. So we need to recognize that trust is not something that exists even when people have lived through a pandemic. And we need to bridge those trust gaps where people don't see a vaccine, always see a vaccine with suspicion, like someone is going after them for something. And this has existed in African countries because there's been a history of medical tourism, medical experimentation on bodies of Africans. So that worry continues to exist, and we need to work on the trust of the people.
Yeah, thanks so much, Rosebel. Short and sweet. And Rashida, last word before we turn it to Lori to close.
I'd just like to thank you, Sarah, and Dr. Joanie and Dr. T and Rosebel covered it really, I think, really concisely. And I think this was a wonderful panel, and thank you very much for having me.
Thank you so much. So I'll just turn it to Lori to close. And then hopefully all of you will join us in the breakout session. Thanks so much. Thank you to all of our panelists.
Wow. Thank you so much, Sarah. Thank you to our amazing panelists and speakers for joining us today. You gave us so much to think about. I just want to pull 3 things out just to summarize and put a button on it. And then we are going to go into our breakout sessions, which are going to really give us a chance to talk to each other directly and have direct engagement. So here's 3 things I heard. 1, we need to be more than just not racist. We need to be anti-racist. Racism is embedded in institutions, in grant making, in program design, even in health commodities. So how can we shift that power? 2, I heard about new modes of solidarity. Winnie talked about gay men who are breaking quarantine to pick up the ARVs and distribute them across their communities. How can we really lift up and celebrate and support and fund new modes of solidarity, especially understanding that trust may not always be there. So we need to bridge those trust gaps. And lastly, I heard about hope. I heard about things being bad, but in some ways things being less bad than they could be. And some of the numbers across a variety of areas moving in the right direction. So how do we build on that momentum by investing directly in communities who are leading the way? They know their solutions. Don't just talk about it, be about it. It's not rocket science. I think Rashida said it very clearly and plainly. These things do not blow your mind. We just need to do them. So thank you to our panelists. Those are just 3 things I heard. Now, at the end of our webinar, we have a discussion to take these conversations into more interactive breakout sessions. And if you're able to join us, we're hosting a breakout session for the first 100 people. We have a link in the chat. When you click on it, it will take you from this webinar to our Zoom meeting room, where we'll do a short overview of our discussion and then break you out into groups. Again, you can go ahead and click on that link in the chat box, and you'll be able to head over to our 30-minute breakout discussion. If you're not able to join us, thank you so much again for coming, and we hope to see you at another GHC Summit 2020 session, or of course, there's always next year. I want to thank again our panelists, encourage you all, take advantage of these breakout sessions. They're first come, first served, and it's going to be a great group, and have a wonderful day in solidarity. Bye-bye.
Hello, everyone. So as people are making their way over to the breakout session, I'm just going to stay here and help direct people. So as Lori mentioned, there's a link there down in the chat. It says to join the breakout session. Please click on this link. You're going to want to click on this link and leave this webinar to go to that session. So just head on over there, but I'm here to answer any questions you might have.